My purpose here is to go further and look at maybe low T is part of this process, but there are other issues associated with cell inefficiency that leads to issues of decreased testosterone production or utilization of the androgen receptor of testosterone. What about testosterone in postmenopausal women? That's been another potential aspect of controversy, and that is, the relevance here is that after menopause, there are decreased levels of estrogen that are produced, and that decreased estrogen leads to lower sex hormone binding globulin, and lower sex hormone binding globulin leads to a release in a freer testosterone. It doesn't bind testosterone like it did before, and so there's more testosterone available biologically. And it was hypothesized that a relative androgen excess during this menopausal transition may be partially responsible for increased cardiovascular death in females because of that testosterone rise. And I think you'll see, we'll bring a lot of information forward to kind of show that relevance is not responsible for cardiovascular disease. It's just another causation, but there are ways, there is that potential to improve estrogen and estrogen replacement so that you can kind of mitigate that factor. But the possibility of DHEA, dihydroepiandrosterone is related to a rise. It's elevated in menopause, and that in itself can increase the androgens in postmenopausal women, and that possibly could be part of this transitional role of estrogen and androgens. And all that means is these are other just theories of, could be this increased DHEA, could it be the testosterone because of the ability of less testosterone binding to that sex hormone binding globulin, which is a protein that's out there and just holding on typically to testosterone. And because of less estrogen, you're not making estrogen after menopause, then with lower estrogen, that causes the sex hormone binding globulin to release it. So those are theories. But there's existing data that shows that testosterone supplementation, low dose, potentially is safe in females. In fact, the benefits of testosterone replacement therapy to treat low testosterone in postmenopausal women and men is substantially outweighs the risks. So those are things that we're going to do a really good job, I believe, in setting the tone in moving forward to kind of bring more of that information out. But these are the areas of debate, basically. And if you're younger and you have earlier symptoms, that's more related to something that's called primary ovarian insufficiency, which is, again, we feel related to cell metabolism, cellular redox, and things that potentially can go wrong, and is going to kind of set again the pace of where we go down this pathway in talking more about cell metabolism and other aspects of improving these areas. But common treatment and why people show up for with menopausal symptoms are the hot flashes and the vaginal discomfort, mood swings, and so forth. Most of the literature and thoughts are that you are at greater risk if you do start at that time. So there is a window, and that number can be debated, and I'm sure we will. But the heart disease, strokes, and blood clots and breast cancer can be significant if you lose that window of treatment, meaning you wait too long. And again, this is the relevance of this whole presentation, is to give you information so you can make good decisions early and make better decisions on, is it even necessary? So the hormonal therapy started before 60 or within 10 years of menopause, the benefits appear to outweigh the risks.